Non-invasive ventilation can be a powerful and effective therapy. This therapy can help patients with chronic respiratory failure subsequent to COPD, neuromuscular disease, restrictive thoracic disorders, and obesity hypoventilation. Many patients with frequent hospitalizations receive significant benefit from this therapy. Often, patients using NIV therapy experience a reduction in CO2 retention, can achieve a targeted tidal volume, and most importantly, find an improved quality of life. If you have any patients in mind who might benefit from this therapy, and to learn more, visit medicalserviceco.com.
Good afternoon and welcome back. This morning's session was geared towards both sleep and respiratory professionals. With more focused education this afternoon, you are in the respiratory track and lectures are approved by the AARC for CRCE. Our next lecture will be presented by Joseph Khabbaza. Dr. Khabbaza is a pulmonary and critical care physician at the world-renowned Cleveland Clinic in Cleveland, Ohio. After completing mathematics and economics degree at Boston University, Dr. Khabbaza went on to receive his Doctor of Medicine degree at SUNY Upstate Medical University in Syracuse, New York. Dr. Khabbaza's internal medicine residency brought him to Ohio State University Medical Center in Columbus, Ohio. He went on to the Cleveland Clinic in Cleveland, Ohio, where he completed his fellowship in pulmonary and critical care. Dr. Khabbaza remained in Cleveland after the completion of his fellowship and shortly thereafter developed a passion for bronchiectasis and NTM, aka nontuberculous mycobacteria pulmonary disease, in addition to generally pulmonary and critical care. Dr. Khabbaza will lecture you on the very topic as the title of his lecture in NTM, Bronchiectasis, What I Wish I Learned in Training. We thank Dr. Khabbaza for his willingness to share his knowledge and experience during today's forum. As a reminder, please enter your questions under the Engage tab. Dr. Khabbaza will answer these questions immediately following his lecture.
Hello, everyone. Thank you very much for having me again this year at the Gene S. Marx Memorial Education Forum. Thank you, everyone from Medical Service Company, who has been very great to work with these last couple of years. Today, I'll be giving a kind of talk really about what's become my clinical passion over the years. I did a little bit of a talk about just general airway clearance yesterday, but I think my big theme with time is about kind of just the basics of nontuberculous mycobacteria and bronchiectasis and what I wish I learned in training. I think a big issue with these pulmonary conditions that require a lot of respiratory support is that we're just not taught a lot about them in our medical training, whether it's internal medicine or pulmonary fellowship, and that has a trickle-down effect to everyone we work with. That if we're not strong with this, then ultimately the patients will get undertreated, which can lead to problems for a long time. So I'm Joseph Khabbaza. I'm a pulmonary and critical care specialist at the Cleveland Clinic, so I do speak about. I give unbranded talks for InfMed for Mycobacterium avium complex. So I do receive speaking and consulting fees from InfMed, and that is my only conflict of interest from the disclosures. So our really basic objectives are to try to understand really the basics of bronchiectasis. What's the definition? What's the pathophysiology? Basics of treatment even, and the same for diagnosis, management. When do we treat nontuberculous mycobacteria? How are they tied in together? And how you as a respiratory therapist can play a very important role, not only in the outcomes of these patients, but in helping the providers who take care of them do a better job at really caring for these patients. As we'll see, they're very undertreated. Now, I always take a page out of the MICSAP is kind of our big board review book in internal medicine. We have a book for each organ system. So when I looked up bronchiectasis out in MICSAP, it had pretty much less than one page in an entire pulmonary section, yet it is such a significant pulmonary condition. But back to our medicine training, we hardly ever talk about bronchiectasis. We learn very much about it, and that unfortunately did not change too much in our pulmonary fellowship. Bronchiectasis it originates from a Greek term. Bronchia means airway, and ectasis means widening. So just stretched out windpipes, essentially. It has a lot of symptoms that can overlap with COPD or asthma. A lot of people have shortness of breath. A lot of people have cough and sputum production. Some people can have wheezing. And also they can overlap with COPD and asthma. It's defined by very inflamed and easily collapsible airways, obstruction of airflow, especially when lots of secretions are in the airways, and also frequent exacerbations. When this destruction occurs in the windpipes, it is irreversible. So once you have bronchiectasis, it's not going to get better, but by letting bugs and bacteria and inflammation sit in the airways, it's only going to get worse with time. And here's just a nice picture from our bronchiectasis website of what a normal bronchus looks like. You see the normal cell walls. We all make normal mucus in our airways. When you go to a damaged windpipe in bronchiectasis, the walls are kind of flimsy. There's a lot of damage to that nice cellular structure. There's increased mucus within plugging up the windpipes. Already you can see if mucus is kind of sitting in that windpipe, not a lot of room for air to go. And within that mucus is just bacteria and bugs, and that kind of brings inflammation with it. That inflammation leads to more destruction of the windpipes, and that's a process that goes on and on. This is a vicious cycle that we will get into a little bit deeper. Again, like I said, what's challenging is the nonspecific nature of symptoms. There's a lot of overlap with COPD and asthma. In fact, oftentimes, bronchiectasis is misdiagnosed as COPD or asthma. Oftentimes, it is treated like COPD or asthma, even when it is correctly diagnosed. So having an understanding of how to treat is very important, because a lot of traditional COPD and asthma therapies can actually make bronchiectasis worse. People get frequent antibiotics that are often inappropriate, which can lead to further issues with resistant bugs and ultimately not doing what's most important, which is clearing the airways. The low index of suspicion amongst providers, both primary care and pulmonary, leads to delayed diagnosis. It's not really high up in the differential of chronic cough. When we look at just the general work of a chronic cough that we learn in training, bronchiectasis doesn't really make that list. We're pretty good with asthma, with reflux, with postnasal drip, or ACE inhibitors, but after that, we're not really good at digging deeper. And that's when patients oftentimes fall into a vortex of being put on different inhalers, different reflux medications, different nasal sprays, seeing ENT and GI. They really get sent through this vortex before bronchiectasis is really considered. As you can imagine, when people have a chronic disease like bronchiectasis, they're going to be going to the hospital more with more exacerbations. They're going to be calling the doctor's offices more. They're going to get more tests. So a lot of healthcare dollars are utilized in patients who have bronchiectasis, especially ones who are untreated or undertreated. Now, again, the big key points that it's often misdiagnosed as asthma or COPD. When it is correctly diagnosed, providers still treat it as if it's asthma or COPD, whereas the physiology is completely different. So excessive and inappropriate antibiotics are a big, an outdated practice where oftentimes, you may know some patients who are put on every month, 1 week of different antibiotics prophylactically, but that practice is very outdated and also no longer really supported in any evidence base. So it was first described actually in 1819 by the guy who invented the stethoscope. The prevalence is going to vary from country to country. Tuberculosis is one of the biggest causes of bronchiectasis as people heal from tuberculosis. So India and China have a lot of bronchiectasis relative to old cases of TB, but in the United States, we can have up to 500,000 patients who do carry the diagnosis. A little bit more common in women and those in older age. And really before the 1950s, it was considered untreatable. Before the development of antibiotics, when people had bronchiectasis, you almost kind of gave up on them. Not much to do, and the mortality was nearly 40% before age 40 in people who had bronchiectasis really before the mid-1950s, before the antibiotics. So pertussis, measles, these are injuries in childhood to the lungs that can lead to people growing up while having bronchiectasis, which can lead them to developing issues down the road with recurrent infections. But successful vaccinations reduce the mortality of bronchiectasis because pertussis and measles, people weren't having it anymore. So you're seeing a lot less cases of bronchiectasis in adulthood as a result. But unfortunately, after that, research kind of shifted away. It wasn't a very exciting topic. And then things really, there was not much progress was made over the years. Now, symptoms, again, cough can be dry or productive, shortness of breath, very nonspecific. Recurrent pneumonia is one of the biggest ones. If I have a patient that has recurrent pneumonias, that's one of my first thoughts. And just having one pneumonia, you can sometimes heal in the lungs to where the windpipes are stretched out a little bit. And that in itself makes you more susceptible to developing pneumonias down the road. People who have asthma or COPD who have frequent exacerbations, certainly we must be considering, are they exacerbating a lot because they have bronchiectasis and chronic bacteria in the airways? Hemoptysis can be seen quite a bit in bronchiectasis, and a lot of people it is their presenting symptom. And GERD or recurrent sinus infections may contribute, and people who have them might be a clue. If you have reflux uncontrolled, that can cause bronchiectasis and cough. And recurrent sinus infections as the bacteria fall into the lungs and seed the airways. And so those are all kind of clues to think about. There are a lot of different causes. Immunodeficiency, we talked about post-infections, a big one. Non-tuberculous mycobacteria, which is something we'll be highlighting a little bit later. Conditions where the cilia are not normal in the airways, so we can't sweep up mucus normally, so mucus pools in the airways causing more inflammation, like cystic fibrosis and primary ciliary dyskinesia. Inhaling toxic stuff, so like stomach acids, for example, can damage the airways and cause bronchiectasis. Airway obstruction, such as tumor or foreign body, will cause stretching out of the windpipes that is beyond the area of obstruction. And obstructive airway disease, so COPD, asthma, alpha-1 antitrypsin deficiency. So these are all conditions that, oftentimes if somebody has a diagnosis of COPD or asthma, we stop thinking that anything else in the lungs could be contributing, but really important to think about bronchiectasis, especially in the ones who do not have controlled disease. And here's just a slice, we'll get into a little deeper about non-tuberculous mycobacteria. Where you kind of see in this scan, a lot of stretched out windpipes in that right middle lobe here. And all that whiteness is infection, inflammation, mucus. You see some scattered tree and bud opacities throughout the rest of the lungs, suggesting more small airway disease as well, with kind of a milder bronchiectatic picture. And to round up the causes, inflammatory bowel disease for separate reasons can cause bronchiectasis, autoimmune diseases. Interstitial lung disease can stretch out the windpipes. Then secondary immunodeficiencies do play a role in the airways, and some of the mechanisms are not really well understood. So here is this cycle, really the vicious cycle that is always highlighted and talked about in bronchiectasis. You get the initial insult, so your initial infection, for example, that causes some inflammation. When you have inflammation, you get a lot of neutrophils come to the airway, and these neutrophil proteases come, which bring along cytokines and cause inflammation as part of the healing. As you start healing, once you have the inflammation, the airways kind of start stretching out a little bit. The windpipes inside the little hairs, the cilia inside the windpipes start losing their function. The airways get remodeled as things start healing. Then that windpipe stretched out. When it's stretched out and loses the cilia, it can't clear mucus normally. As mucus builds up, normal bacteria we breathe in gets colonized in the windpipes, then eventually builds up to a point where airway infection develops. Then once that infection occurs, that cycle begins again with the inflammation. This can go on and on and on until people progress to points of no return sometimes. So the diagnosis initially we make with a high resolution CT scan. Once we have a scan and are aware of the diagnosis, then we oftentimes get spirometry and follow that. And that's where a respiratory therapist is almost always involved and gets to lock eyes with bronchiectasis patients. We get lots of sputum cultures frequently to see what bugs are growing. Frequent sputum cultures are so important in the long-term management. We check immunoglobulins and alpha-1 antitrypsin to look for secondary causes. If we suspect primary ciliary dyskinesia, we check the nasal nitric oxide. We'll get a cilial biopsy, autoimmune serologies, and checking HIV to see if any of those secondary conditions are part of the picture. Now, again, when you have suspicion, we need to get a high-res CT scan. Oftentimes, people with early bronchiectasis or early chronic infections, they can have clear x-rays. So we need to have an index of suspicion. Now, here's a slice of different kinds of bronchiectasis. And here is a bronchus that kind of terminates within a cyst. So that's not a focus of, that's not like a cavity from a pneumonia, but that's just where an airway terminated and then got stretched out from the inflammation within it. B, here's a classic one where the bronchi doesn't taper as it travels to the periphery. So it just looks like a straight rod coming out to the periphery. This is the sign that kind of looks like a ring where the windpipe is bigger than the blood vessel. So that is a classic sign of bronchiectasis as well. And when we see something like this here, that is just a mucus plug that is stuck within a stretched out windpipe. What's the main treatment? First, we treat the underlying disease. If you have immunodeficiency, we replace your immunoglobulins. If it's due to nontuberculous mycobacteria, we treat it. If it's due to allergic bronchopulmonary aspergillosis, we do steroids and sometimes antifungals. People with autoimmune disease, we have to optimize the treatment of that condition. Recurrent aspiration needs to be taken very seriously and treated medically and sometimes surgically. We didn't get into tracheobronchomegaly much, but that is something that you would treat with a non-invasive positive pressure ventilation. Some people who do have asthma, that kind of phenotype with the eosinophilic airway inflammation, those are the people where we would want on inhaled steroids. So we have to, again, optimize the treatment of the underlying cause. But once we do that, we're still faced with the bacteria and the bugs that are taking up space in those airways, causing a lot of that inflammation. So it's very important, like I said, to get frequent sputum cultures, because using specific antibiotics to target exactly the stuff that grows is a very targeted and efficient way at trying to treat what is growing in there. To people who have recurrent pseudomonas or recurrent types of infection, when they have this chronic neutrophilic inflammation, that's when we have found a role for daily macrolides, so especially as taking azithromycin daily, not because it's an antibiotic, but because it has a mechanism where it blocks the neutrophil elastase from causing inflammation. And people do very well on that. So if they have more than 2 flare-ups a year that are infectious, we do start daily azithromycin. And then some people, we do inhaled antibiotics every other month to try to prevent the buildup. So airway clearance is crucial. That is probably your most important treatment though. Okay, so everything we're doing before, we're treating underlying diseases, we're treating specific bacteria, but the only way we can break that cycle is by physically getting mucus and sputum out there. So antibiotics, let's kill the bugs that we know are living in the airways, but antibiotics will not be as effective if we don't efficiently clear out mucus and secretions from the airways. And back to a different diagram of this vicious cycle we talk about, where the inflammation, so you get the cytokines, the neutrophilic enzymes, these bacterial byproducts that further impairs the clearance, the cilia stop working, the airways produce more mucus, more obstruction develops, more bugs start hanging out in the airway, and these are probably the most common ones that we see. Haemophilus influenza, Pseudomonas, staph, those are really the biggest ones. Then you get more bronchial dilation, airway destruction, and on we go. So as the airways get full, you can get all the best antibiotics in the world, but if you have an airway like this that's just filled with dry secretion filling it up, it may be very hard to eliminate all the bacteria because you're not having the source control component. It is really well described, and a lot of that evidence really comes out of the cystic fibrosis literature. You clear the airways, you're going to have less mucus, you're going to have improved ventilation, there'll be less obstruction, less bacterial load, and also by less bacterial load, you'll have less infection, and ultimately less exacerbation, which leads to less healthcare utilization, higher quality of life. And it's just overall that is our goal, to minimize exacerbations. And airway clearance, doing it right, is a very underutilized therapy in pulmonary medicine because it is time consuming. Now, one of the most, it's time consuming both for the patient and the physician. And, but it's important that people around the patient, whether it's respiratory therapists or the providers, are able to communicate in appropriate detail why airway clearance is being done, what to expect, and why it's so important long term. So exercise is probably your most important form of airway clearance. We recommend 150 minutes of moderate intensity exercise per week. And anyone who qualifies for pulmonary rehab should be in it immediately. That is one of the most important medicines for airway clearance. Now, each institution will have their own initial airway clearance regimen, but we generally start with nebulized albuterol, like to try to open that airway up a little bit. We then do hypertonic saline, which is saltwater nebulized. By putting salt on dry mucus, that starts pulling water and moisture onto the mucus so that hopefully it can start becoming more mobile and coughed up out of the airways. We then have the patients breathe into an acapella, 20 breaths at least. And we do that sequence 1, 2, 3 at least twice a day. In patients who do not respond to that initial airway clearance regimen, we then will use a high frequency oscillating vest on the chest, which really can help shake out mucus. There are different breathing maneuvers, postural drainage, and percussion that can be used in the appropriate setting as well. So again, at our institution here in Cleveland, we kind of have a 1, 2, 3 punch that we start everyone on twice a day. I see here my saline covered a couple, or the albuterol covered a couple of the words there, but we start nebulized albuterol, and again, it's important this sequence. Think about it. We're opening the airways, then we're throwing in salt water into the dry mucus, and then we're blowing on an acapella, which puts a back pressure into the lungs. It pushes air beyond the areas of mucus and obstruction. Then it has a flutter valve that starts trying to shake off the mucus and slowly shear it off the airways. It can take 3 or 4 weeks before a twice daily regimen of this starts expectorating sputum. So it's important that patients have appropriate expectations. And this is not going to happen overnight. So often I see patients on referral who have been put on nebulized medicine, but were never told what to expect. They didn't find it helpful after a couple of days and they stopped. So very important, that education component to patients. Here's a picture from when I was trying on an Aplo vest that was in our office one day. Now for me, it was very comfortable. It kind of felt like a nice massage. They have different settings, but I don't have bronchiectasis, and it made me eventually start coughing by having the natural secretions in my airways start moving out forward. So these are vests that you can get from any DME, and certainly a medical service company could very easily get them arranged for you as well. So these require a separate insurance order form process, but it's pretty easy to get approved if you documented that they were still having issues with airway clearance despite using an acapella or hypertonic saline. Now, I think one of the things I wish I learned most in training are some of the harmful treatments. There was really no mention of this in my training at all. I think in many of our trainings about things that we do to these patients that might actually be hurting them. Antimuscarinic agents, ipratropium, tiotropium. So these are Spiriva, Incruz, Duonebs. These are medicines that probably most of the patients you see are on. But if they have bronchiectasis and sputum issues, this class of medication, they dry out secretions, and it makes it harder to clear the airways. I can't tell you the number of patients I see with bronchiectasis and issues with airway clearance who are on scheduled duonebs or other of these agents and still having issues with clearance. So that's the first move we often do, is stop those medications. We reserve, it's okay to use them if the patient actually needs it. So if their COPD is not controlled, then adding that on is acceptable, especially if they find benefit once it is on. Inhaled corticosteroids, almost all of our patients seem to be on inhaled corticosteroids, should not be a part of baseline bronchiectasis therapy. So many patients with bronchiectasis are treated as if they have asthma and put on the same inhalers that we give asthmatic patients. When they flare up, they're given prednisone and antibiotics. This is harmful therapy and increases the risk of them developing nontuberculous mycobacteria and other lower respiratory infections, which of course would further worsen their bronchiectasis. So reserve inhaled steroids for those who have an asthmatic phenotype, so an asthmatic component really to their airway disease, to their bronchiectasis. It is okay if they demonstrate a need for it. If a patient who's put on an inhaled steroid doesn't feel better on it, that's reasonable to stop it as well. Now, another potentially harmful treatment, which we still see probably a little bit more often than we should, is that week of alternating oral antibiotics every month. Many patients are put on, take doxycycline the first week of the month, and the next month take Augmentin, and the next month take azithro for a week, and do such a cycle. There's no evidence on that. It's a very outdated practice, and it comes with risk of developing resistance for the bacteria. So having a targeted approach with specific antibiotics based on culture data is the safest and most appropriate thing for the patient. But at least people who are doing this did recognize that bronchiectasis is a disease associated with chronic infections. Now, so the main things that I wish I learned to summarize about bronchiectasis, so not just in internal medicine residency, but even in pulmonary fellowship, where we're supposed to learn everything about the lungs. And it's not my program's fault, it's just the nature of the field. I think very few centers do you get a really thorough bronchiectasis training. So bronchiectasis is common, it's not rare. We can see it everywhere. And it's sure it is a lung disease, but we also have to think about it as a chronic infectious disease. The importance of airway clearance was nothing that was ever stressed upon me early in my training. It's good to have a baseline airway clearance regimen. And then when you flare up, very important to increase what you do for airway clearance. And very important to know that bronchiectasis is neither asthma nor COPD. Flares should not be treated the same way. Flare-ups of this different lung disease should be treated in its own unique way. So those are really the main points from just a straight up bronchiectasis standpoint. Now, nontuberculous mycobacteria, these are types of bacteria that are everywhere in our environment. Okay, they're in water, they're in soil. That's really our entire globe, and they're not very serious bugs. We're all exposed to them. We all breathe them in. You know, we know of tuberculosis and leprosy; those are kind of mycobacteria we know a bit about. Those are a bit more serious, but they're not in the non-tuberculous mycobacteria category. What's challenging about non-tuberculous mycobacteria is that they form biofilms. These are really thin layers of slime that coat the walls or windpipes. They coat pipes in our plumbing systems, but they also coat our windpipes. The prevalence of non-tuberculous mycobacteria is also increasing 8% per year in terms of people with lung disease. So at that rate, that's doubling every 10 years or so. So it's kind of like the stock market. Every 10 years, what's in the stock market should double what you have, and that's what's happening with NTM as well. So it is everywhere, but these biofilms really can be a stubborn place where antibiotics don't get very well. Now, I took out the MICSAP infectious disease board review book. 190 pages, less than one page was on these very important and serious bugs. And again, in our training, including pulmonary fellowship, this infection was made to feel that it was not too big a deal. So there are over 200 species of non-tuberculous mycobacteria, where we're finding more and more new species every year. 80% of the ones that cause lung disease tend to be Mycobacterium avium complex, or MAC. MAC is the most studied one. It's got the clearest diagnostic criteria and treatment regimen. That's the one that we know about the most, that we think about the most, but it does have some cousins that do cause lung disease as well. But because these are slow bacteria, they kind of just hang out in the airways. We've all been exposed to them. We've all breathed some in, but we just cough it out. But if you have bronchiectasis, if you have a predisposition for not clearing secretions normally, then it's possible you may inhale these bacteria, and then they might stay in your lower airway and not clear out. Then they set up shop in your alveoli and then slowly grow over many years. They live inside of our alveolar macrophages, which are immune cells in our lungs. And they also form those biofilms that we talked about. So very hard areas to get a lot of antibiotics to. But when we go into the diagnostic criteria, you need to meet three separate conditions. You need to have symptoms of infection. So we think of the respiratory symptoms: chronic cough, shortness of breath, fevers, chills, but a lot of people can have non-pulmonary symptoms such as chest pain or anxiety or weight loss or fatigue. We need to have radiographic changes, and we'll get into them. So we need to show that, hey, it's affected the lungs. Because these bacteria are everywhere, oftentimes if we leave a sample, if we just drank water earlier and there's some MAC in it, it may show up on a sputum sample we leave. If everyone at this conference right now was given a sputum cup, we had you cough up a sample now, and then we sent it to the lab. By the end of the day, if we had rapid testing, there probably would be a handful of people where MAC showed up only because it's in your water supply. But that doesn't mean you have MAC lung disease if you don't have radiographic changes or clinical symptoms. It just means it was in your environment recently. That's why we like to have multiple sputum cultures to grow the same species. If you're doing a bronchoscopy, one culture is enough. I think one of the biggest challenges is the delayed diagnosis that occurs just because there's a low index of suspicion. A lot of healthcare providers do not think about nontuberculous mycobacteria much, including pulmonologists. The symptoms are very nonspecific, and like we said, some of the symptoms are non-respiratory. The symptoms can overlap with the underlying lung disease. So if you have COPD, you're certainly at risk for developing NTM lung disease. But if you're short of breath, your providers oftentimes think, well, that's due to COPD. It can't be something else. And the X-ray can be normal early in disease. That is a big, that's tough, because when we have clear X-rays, oftentimes the natural thing to think is, there's no infection within the lungs. But that is not true. 57% of patients have symptoms for over 1 year at the time of diagnosis. A patient I saw just several hours ago this morning first developed symptoms of hemoptysis in 1998. She did not get a diagnosis of MAC pulmonary disease until 2011. As you can imagine, she's had a very challenging course since then. So not uncommon for many years until people are diagnosed, because we're not trained to think about it often. Again, it's growing both in men and women every year, and about 8% per year is the average. So like we said, every 10 years, the prevalence will double. The number of people that have, it's going to be more. And in the next decade, the number of people ages 65 and older are going to double as well. That is a population where we see a lot more NTM lung disease. So it really is everywhere. It's just we're not looking forward or thinking about it as much as we should. Now, what are the biggest risk factors to developing NTM lung disease? So chronic lung disease is the biggest one, especially bronchiectasis, hugely increases the risk. Asthma, COPD, for sure. People who have low body weight or thoracic skeletal abnormalities, they don't clear secretions normally, some chest wall changes, and people on immune suppression. So immune suppression, we think of chemo, we think of various biologics, but oftentimes we don't think about inhaled corticosteroids. Inhaled corticosteroids are a form of immune suppression that is specific to the lungs. So it is well described that people who are on inhaled steroids are at higher risk of developing NTM. And so that's why it's so important that we are always looking to minimize the amount of inhaled steroid any patient is on. And here are some of the studies that kind of early on showed these associations. We're trying to see who did it occur more in. And really, when I see recurrent pneumonias, that is one of my biggest red flags that something else might be going on. If you have NTM living in your lower airways, you're just more susceptible to having traditional bacteria causing infection, the ones that respond to antibiotics within a week. So people who have pneumonia more than once, I'm always digging around and getting cultures to see. But that is the biggest comorbidity, history of recurrent pneumonia. Now, other registries, I've been looking. Recurrent pneumonia and GERDs were very big in this study as well. And reflux also can cause recurrent pneumonia, if we're having some bacteria from our esophagus ending up down in our lungs as well. So this has been studied quite a bit. So here are just some different slices of how NTM pulmonary disease gets involved, but it's a similar process to that vicious cycle. You get acute infection, or just the chronic infection of the NTM living in the airways that causes inflammation, healing, which then leads to worsening lung destruction and bronchiectasis, and it cycles on and on. In the top left there, you can see fibrocavitary disease. It can look a lot like tuberculosis. And then the other scans, you'll see different nodular bronchiectatic changes, where here you kind of see stretched out windpipes, some scattered small nodules and tree bud opacities, some focal areas of bronchiectasis. Here's a nice picture of a stretched out windpipe, and these white areas are just dry secretions, just taking up all the space there. And also here are some focal areas of cystic bronchiectasis as well. What often comes up, the chicken or the egg analogy with bronchiectasis and NTM. Certainly having bronchiectasis makes you more prone to developing NTM, but also having NTM makes you more likely to develop bronchiectasis. But as long as we understand the basics of treating each, it doesn't really matter what was first, as long as we treat what's in front of us. And that's really most important. So again, these are kind of more studies that looked at comorbidities. And this was the one out of Denmark that really highlighted the fact that people who had bronchiectasis had a 187 time greater odds of developing NTM lung disease compared to those who did not have bronchiectasis. So that is really your number one risk factor for developing an indolent infection like a nontuberculous mycobacteria pulmonary disease. Now, this is really the common teaching that we had both in residency and pulmonary fellowship. NTM pulmonary disease, MAC, rarely needs to be treated. It's 3 antibiotics for sometimes a year and a half, sometimes IV antibiotics. So the treatment's going to make you feel worse than the disease. So we're almost always taught to make patients be too scared to agree to go with treatment. It's very easy to talk a patient out of treatment with NTM, depending on the wording that you use. But these two very common teachings that are still employed by a lot of us in pulmonary and infectious disease today are not right at all. They're very erroneous on all counts. And that is something that I really wish I learned more in my training, because I feel like I could have intervened earlier in the trajectory of these patients' path, because ultimately most of them are going to need to be treated. And by delaying it, we're not really helping them. So what happens in reality? Most patients should be treated. When we look at more recent studies where we put a ton of patients in this watchful waiting category, over 60% of them progressed to the point where their imaging worsened and their symptoms worsened, and then they underwent treatment. So the later you treat, the more destruction there is in the lungs, and then the harder it is to cure. Smear-positive cavitary disease. We know if you have a smear-positive culture, that means there's a lot of mycobacteria. And if you have a cavity in the lungs, which means essentially necrosis, just chewing out holes in your lungs, those are both markers of more severe disease, and that is likely to progress. So most people should be offered treatment up front, very different than what most of us have been told. And the most recent NTM treatment guidelines from 2020 also switched to this now, saying, hey, most people should be offered treatment up front, but it does require a shared decision-making discussion with the patient and the physician, because some patients may not want to treat. The reality is most patients tolerate the 3 antibiotics just fine. Some blood work's needed, some other kinds of monitoring are needed, but we treat with azithromycin, ethambutol, rifampin for 12 months after the first negative sputum culture, and the vast majority of patients actually treat. I actually tolerate. I'm one of the pulmonologists who treats my own patients for NTM. I manage their airway clearance and NTM. So I've developed a lot of experience with antibiotics over the years, and certainly most tolerate more than I ever imagined. Now, we know when people are treated with guideline-based therapy, really based on the 2007 guidelines, they're more likely to improve. The cure rate can be as high as 80%. Imaging improves, symptoms improve, but most people are able to get their cultures negative. Now, this study was a survey done by one of the world experts in NTM and bronchiectasis to see, of the people who are treating, how many were actually using the guidelines to treat it? How many people had their patients on appropriate therapy? Now, these are in doctors who are choosing to treat. So we have big challenges because a lot of people choose not to treat, but in the doctors who do treat, only 13% actually had patients on regimens that met the ATS-IDSA guidelines. 87% of people who are being treated were on incorrect and potentially harmful regimens. 30% of those patients were on regimens that increased the odds of developing resistance inside the NTM. And once macrolide resistance develops in there, it becomes almost very unlikely to cure. So very few people had patients on a correct regimen. And the ones that had them on wrong regimens actually had them on harmful regimens. So very important to treat earlier, but also to treat them on the right regimen. So trying to get them to at least a provider, somebody who has a special interest in the treatment of these patients. So in summary, here's what I wish I learned about bronchiectasis. I wish I learned how underdiagnosed it is and how misdiagnosed it is. I wish I learned how it shouldn't be treated like we treat asthma, like how we treat COPD. I wish I learned that some of the treatments for COPD and asthma are actually harmful for people with bronchiectasis. And I wish I learned a whole lot about airway clearance. So in addition to treating the underlying cause, I wish I knew the importance of that airway clearance just for short-term benefit, but also for long-term prevention of infection and quality of life. But I wish I learned about nontuberculous mycobacteria lung disease. I wish I learned how NTM is everywhere. It wasn't just a rare thing that occasionally popped up on a culture here and there incidentally. Wish I learned we should be checking frequent sputum cultures for AFB. Anyone who has a predisposing condition for developing NTM, so COPD, bronchiectasis, asthma, if they're making mucus, I always want cultures. If they're in the hospital with a pneumonia, I always want cultured. If mucus is being made by a pulmonary patient, getting that cultured for regular bacteria and nontuberculous mycobacteria can really change the trajectory of a patient's life, really. I wish I learned that most patients should be treated and that most patients actually tolerate the 3 antibiotics that we've often told them that they will not tolerate. And then once treated, they should be patients for life. Once we've treated them and eliminated the bacteria, they still have bronchiectasis. They still have the predisposing factors to develop it again. So we should always keep an eye on them and at least checking spirometry 1 to 2 times a year in monitoring for any signs of recurrence. Now, how can you help as a respiratory therapist? Bronchiectasis patients see respiratory therapists quite a bit, or they should be at least when they're seeing their pulmonologist. Because a respiratory therapist can be very helpful to understand the basics of nebulizers. There are a few types out there, so to learn about the most common ones that your patients have and how to troubleshoot issues. Just a basic knowledge of that, you really become a big service to the patient when you're doing their spirometry, and then they're able to bounce nebulizer questions off of you. I think just being aware that knowing what patients are using in their nebulizers, so being aware if a patient's on Spiriva or the ipratropium, which is in duonebs, and you notice they're still having issues with chronic productive cough, you could let their pulmonologist know or their provider, hey, just so you know, Miss Smith has a productive cough, but she's on these medicines that might harm it. Just wanted to make you aware. Just a little nudge. None of us really mind, and that can be helpful. Sometimes we overlook these things. And now just a basic airway clearance knowledge, really just knowing how to teach a cappella and having a cappella handy could be very, very valuable, where you can teach patients how to use it. And also those who you see again who are on a cappella still with issues, you may tell them to ask their physician if a vest might be appropriate for them. So kind of knowing the patients, and if they're producing sputum, try to give them some tips and point them in directions of discussions they can have with their provider. Now, I think a big one, well, we're really good here during spirometry. If a patient's starting to cough up some mucus during testing, our therapist grabs a cup, patient coughs it in, and then they let us know, hey, we have some sputum. Do you want to put in culture orders? That is a way to prompt the physicians who oftentimes are not thinking about cultures to order regular respiratory cultures and AFB cultures. You may help a person get a diagnosis of NTM lung disease years before anybody thinks about it, just by having an index of suspicion and by capturing a sputum specimen if a patient makes it. You can also look into just having a set protocol at your office. If sputum is produced during testing, have a reflex order from the providers that you will then send it for regular respiratory cultures and AFB. So you can really make a big difference just with a basic knowledge, understanding of the patients who have chronic productive cough. So that kind of concludes my talk. This is my last slide, which usually does very well on in-person talks, but no opportunity to hear any laughter to this one. But certainly let me know if you have any questions, and I'm always happy to talk about bronchiectasis, nontuberculous mycobacteria, and airway clearance. Thank you.